Hi ER nurses, this is Victoria, your ER nurse educator, and I'm here to tell you guys about a resource that I put together that's going to be on every single crash cart. This is adult oriented, but please remember, for those of us that are PALS certified, which should be all of us, or will be all of us very shortly, that the main differences with PALS are going to be how we get into a cardiac arrest. It's usually airway, but more importantly, the dosage differences for the medications, as well as the joules that we're shocking with. All of that information is weight-based, and it's going to be on that Barlow tape. So that is the long piece of paper that has different colors, and the colors are dependent on where that little heel falls. If that pediatric patient is under 50 pounds or 25 kilos, that's when it applies. Otherwise, we're going to be using ALS. If you don't know if your patient is under or over 50 pounds, that's why we use the Barlow tape. If their heels are past it, then we go to the adult. Okay, anyways, so this is going to be on every crash cart. It's an algorithm booklet that I put together. It's the updated 2020. There are some very small changes that American Heart has made for 2023, but they really have more to do with the with finding ROSC and some quality that we're able to run with some metrics there. So the algorithms are the same. On the front cover here, we have the wheel of CPR. I love this because it's simple and it's important. Remembering that good chest compressions, high quality compressions, is truly, truly the best way to save a life. We've run a few different of our pop-up sims, both at Maine and at I-35, and I put together this resource because there's some trends in our practice, and I want to make sure that we are giving our patients the best quality efforts that we can. So first off, we recognize, we shake and shout, we check for breathing. There is no breathing, there is no pulse. High quality CPR from the get-go, okay? Remember, we're going hard and fast, so we're pushing in right at that between the nipple line on that sternum for about 2 inches deep, and at a rate of 110 to 120. So whether you're humming Staying Alive or Baby Shark, that's the rate that we need to be at, okay? Once you have started those compressions, you're asking for help, then it's very important that we're beginning to initiate rescue breaths as well. A very common trend, which was surprising to me, was that we were giving continuous compressions with every doing breaths with the bag valve mask without pausing compressions. And that is practice when we have an advanced airway. With an advanced airway, you are going to be giving breaths about every 6 to 12 seconds. But what you're doing, if you're continuing compressions and giving those ventilations, is the air isn't actually able to go anywhere, and it's not actually making it into the circulation. So it's very, very important that it is 30 chest compressions to 2 breaths, okay? Just as we do with bystander CPR, you continue to do that in hospital until we have an advanced airway. Okay, the other major trend that I saw was a little bit of a sway from our standard algorithm, in the sense that we have 2 minutes of CPR, switch providers, and we're doing a pulse check. That pulse check is less than 10 seconds, but at least 5. Carotid or femoral is an excellent place to check for a pulse as well. After the pulse check, we're identifying the rhythm. How do you identify the rhythm? On the Zoll defibrillator, okay? So the pads are on. We can see that there's a rhythm displaying because we have our little cardiac leads that are in that defibrillation pad. If you are unsure, if you are the one by the crash cart and you're like, I think it's VTech, but I don't know. You can always press the Analyze button, okay? The Analyze button takes about 15 seconds, and it will tell you if it's a shockable rhythm or not, okay? This is not a time to feel bad about your knowledge, but to utilize your resources so that we can take care of our patients the way that they need to be cared for. And not all of us are perfect in every moment, and if you have any doubt, I want you to use your resources, okay? Including this one. Okay, so you can press the Analyze button, shock if you need to. After the shock, resume those chest compressions. Then we're going to talk about medications. Because if you think about it, if I'm giving medicines and I'm not doing compressions, they're not going anywhere. Another interesting trend I saw in the few different ones that we've put together, our pop-up sims, is we weren't flushing those medications. So give the epi, give the Immunerone, flush them as well, okay? Otherwise they're just sitting in the tubing and, again, not going into circulation. Okay, so just to reiterate, our circle of CPR is 30 chest compressions, 2 ventilations, unless we have an advanced airway. I'm going to do a pulse check, check the rhythm, shock if needed, resume CPR, and then consider our medications. As we know, all patients that are in an arrest are able to get epinephrine. Epi can be given 3 to 5 minutes, so just stick to that 4 minutes, okay? Every other pulse check, let's give some epi. Okay, let's jump in. So when we open it, you have a paper flow sheet right here. I'm going to go ahead and pull this out for you. This flow sheet is very helpful, but it is not to replace our Epic charting, okay? Everything that's included on here are things that should be included in your documentation on Epic. Remember, we're scanning our medications. We are using our 5 rights. When you are telling me that you gave epi, I need to know how much and where. Do I assume that you gave the full dose and that you gave it through an IV? Yes, but documentation doesn't have it. It didn't happen, okay? I can't make that assumption when we go to court or when we're looking at it afterwards. Please make sure that you're documenting accurately and adequately. This form can really help you with that. Some other big takeaways that it has are the people that are involved. We want to know who you had helping you and what you did precisely for the patient. It isn't just the medications, it isn't just the chest compressions, but what was the rhythm? What did you shock? When did you shock? When was the pulse check? All of those different interventions are listed on this form and need to be included in your documentation, okay? It's an extremely important thing to give us a full picture of what happened every time. It can be a bit of an exhausting note. If you need help with your note, you can always call me, or your house supervisor, your charge, can kind of help take care of some of these other steps while you are giving a very precise documentation flow sheet of what occurred. Okay. That's this form. On the back of it, it actually has a debriefing checklist. This is super important, especially if we had a code that things didn't go as well as we hoped. It can be a very helpful thing to sit back and kind of think with your teammates about what happened. Okay, I have this checklist here. Remember, these are coming from things that I witnessed and things that were concerning based off our simulations. So we're going to start our compressions right away. Right away. If you have any doubt that your patient is not circulating correctly, is not ventilating, meaning they're not breathing, they have no pulse, they're not breathing, start compressions. If you were mistaken, worst case, they push you away. But if you aren't sure and you delay, you could be taking away some vital moments to that patient possibly making it. So check, shake and shout, check for breathing. Hey, are you okay? Start those compressions. Okay. Need to be supine, meaning completely flat with a backboard. If you don't have a backboard, The only time it's okay to not have a backboard is if you're literally on the floor. Our mattresses aren't the comfiest in the world, but they do have some cushion, and you're not going to be doing adequate compressions without a backboard. Your Zoll defibrillator also will not be able to give you adequate feedback about your compressions without that backboard. There have been a few different instances lately that the backboard has not been utilized. It is on the back of every crash cart. Put a backboard. Best practice is to place that when you're rolling the patient to put the back defibrillation pad on. Okay, and again, 30 to 2. Hard and fast, 30 to 2. With our ventilations, again, please pause. Please pause. You're not ventilating your patient if you're doing continuous compressions. Make sure that you are opening the airway adequately. You can only really do this if they're flat and supine. If they are a trauma patient, we're concerned about C-spine, you just do the jaw thrust rather than tilting back, but pushing open that airway, okay? And then when we get our crash cart, turn on that defibrillator. You can use the analyze button if you need to, and follow the algorithms. Okay. The algorithms are all in here. I wanted to bring your attention to that it's not just if your patient's heart has stopped, but if the heart is having a hard time. So we have bradycardia as well as tachycardia algorithms in here. And pretty notably, we've got the algorithm for a pregnant client in cardiac arrest, okay? The most notable differences with this client is it's not one, it's 2 patients. And so how can we regain circulation for both patients? One, we're going to get baby out as fast as we can. So best practice is within 5 minutes. So if you have a mama who's starting to circle the drain, get help and get help fast. This is something that OB as well as our attendings are trained in. I hope it never ever happens, but we need to be prepared if it does. So not only are we going to be having a bedside C-section in this instance, but before we're able to do that procedure, within the first 5 minutes of the stopping of circulation, we need to push the fundus to the left. So we're going to divert the uterus over to the left so that we can open up that vena cava because baby's sitting right on top of it. So push that baby bump over to the left side. You're going to have multiple hands in there. So someone's doing compressions, another one is pushing the uterus over until we can get baby out. Okay, awesome. Both mom and baby will have the best chance of survival with baby born. So call for help. Medical alert, code blue. Then medical alert, code labor. Get hands as fast as possible. Okay. This last piece I wanted to draw your attention to, I have a folder in the back here that is if the resuscitation attempt was unsuccessful, if the patient expired or deceased, the paperwork that's necessary for you. All of these documents are available pretty easily on Bagot Street. It's on Policy Tech, as well as your house supervisor will be able to help direct you as well. But for if in whatever case the house supervisor is not available, or if you're I-35 and you are a house supervisor, these are the documents that you'll need. This first one, the expiration disposition sheet, is very important, as this will follow the patient from bedside to the morgue to the funeral home. And the reason why it's so important is for the legality of the custody of the deceased person. It's very important that we have a trail of who was involved in the care of this client. Even after they have expired, we still are very careful and giving dignity to this deceased client. This document helps us track who and where this patient is going and who they're with. So please be sure to fill it out completely for the area that you are in. For us, it's going to be body released from the unit being the ER, and then the funeral does not pick up in the unit. All of our patients go to the morgue, so they're going to be with transport to the morgue. We need all of it filled out, including signatures and dates. if you had any questions, which I myself would also have questions about the to-do list, Bagot Street has this workflow that you are able to print off and check off as you go. I have put a master copy in the binder, but you're able to print one off yourself if needed. And it has 9 full steps, but not all the steps are going to be applicable for your patient. For example, calling about the autopsy. Autopsies are usually necessary for an ME case. Most pediatric patients are going to automatically be an ME case, and some adult cases are medical examiner cases. It gives descriptions of what to kind of help the discussion with the family and the resources to give to them. Remember, this isn't so much nursing responsibility to hold those conversations with the family, but to help advocate that the provider is doing so. We have, first of all, that we're notifying the family. Again, that's for the provider to do. Calling for chaplain, and then calling our organ and tissue donor. Again, that's usually house supervisor, but it's something that we need to ensure is happening within the first hour after time of death is called. You can always call before too if you if the family is feeling like they're going to be withdrawing care, things aren't looking well, you can always call early, but it has to be done within the first hour of from the time of death. Okay. It has something on here about notifying other agencies, so the nursing home, for example. And then how to prepare the body for transport. That's probably the most important aspect on here, number 8. And then who to call for transport, etc. Okay, so all of this information, as well as our policy with the expectations of how to care for the client who has expired, will be in your handy dandy notebook on every crash cart. I hope you found this helpful, and I hope it helps improve our cardiac arrest attempts. I know it doesn't happen very often, but when it does, it's a very, very, very important time that we are taking the time to do it right. Okay, thank you all very much, and get your RQI done. Okay, bye-bye.